Sometimes there's no one else who loves me like you used to. Sometimes we're not ourselves. There's no one I can turn to. And I know all the feelings that we shared are in the past. And I know your relationships are never meant to last. And I'll take some time, but I'll be alright. We're moving on, we're moving on. I know time
शशांक आप शुरू कर सकते हैं। आई थिंक सर के पास टाइम नहीं है ज्यादा।
ज्वाइन करते हैं। I will हेलो
म्यूजिक बंद करने।
यस मैम।
सर ज्वाइंट।
मैम सर ने बोला था 5 मिनट में ज्वाइन कर रहे हैं सिर्फ। यस मैम सर हैज ज्वाइंड।
वी कैन स्टार्ट।
यस स्टार्ट करें।
यस यस।
Yeah, please.
Jai Hind to all. Welcome everyone to day 8 on this national webinar series. We a great honor. I shall now introduce our keynote speaker of the day, Mr. Siddheswar sir. Welcome you, sir. Sir is currently serving as an associate professor at Tirthankar Parshvanath College of Nursing, TMU, Moradabad. Sir holds a master in surgical nursing with a dermatitis prevention and is currently pursuing a PhD nursing from same university. He has
Sir not
accumulated.
sharing the slide, शशांक जी।
Yes, ma'am. Yes.
यस।
He has accumulated over 14 years professional experience, including academic leadership role as professor, principal, and vice principal in institutions across India and Nepal. His prior association include esteemed institutions such as Chetwan Medical College, Nepal, KLE Institute of Nursing Sciences, and RB Med College of Nursing, Bengaluru. Sir served as program coordinator for Master's Nursing Program and contributed to curriculum planning, infection control, faculty development, and NAAC coordination. Sir published multiple research articles in national and international journals addressing topics such as COVID-19 knowledge, aseptic technique, and patient safety. Notable publication works in Journal of Nepal Medical Association, Asia Pacific Allergy, and International Archives of Biomedical and Clinical Research by Sir. Sir has also contributed to text chapters and received patents in healthcare innovations, including smart IV drip monitoring system and GIS-based diabetic care monitoring, AI-enabled attendance and tracking system. Sir served as resource person as various workshops, conference, including those on cardiovascular diseases, critical care, and nursing theory integration. Sir holds membership in INC, NNC, KNC, and NTAI, and is proficient in multiple languages, including English, Hindi, Kannada, Marathi, Tamil, Malayalam, and Nepali. Sir, today we'll be speaking on the topic of oncological conditions. We are truly privileged to have you, sir. The virtual stage is all yours, sir. Thank you.
Thank you. I hope this is Shashank, if I'm not wrong.
Yes, sir.
Yes.
Okay, thank you, Shashank, for the nice intro. And I'm really obliged to be associated with your institution. And I sincerely express my gratitude to Madam Dipti Shukla for considering me as one of the eligible speakers in your webinar series related to adult health nursing. This is, I think, first time in Uttar Pradesh that I'm associating with an organization as a resource person, I guess. After Bareilly, I think once I'd been to SRMS, if I'm not wrong. So for this, I'm, sincerely thankful to your organization and especially to Principal Ma'am, Deepti Shukla ma'am.
Thank you, sir. Jai Hind. Thank you so
Thank you.
much. I
Thank
welcome
you,
you
ma'am.
to Samarpan Institute of Nursing and Paramedical Sciences. We
Yes.
indirectly connected with my very close friend, Santosh SU, sir.
Yes.
And
Yes.
today you are here on the platform. And we are very
Right.
happy to have you with this series. And it's good to be have good speakers and their particular fields. And when I found you, I just said, just asked to sir whether sir is available for a class. And
Yeah.
just see your gesture, you immediately said, yes, I will be available for the class. And in the very much of rush situation today, as you are having so much
Yeah.
of the previous commitment, then also you are presented here for your class. Thank you so much, sir, for being so great for us. And yes, in the future also, definitely we will be having you. So today you can start your class as early as
Sure.
possible, as you had to you are
Yeah.
just bonded with some times. Thank you so
Yes.
much
Yes.
and welcome
Thank
on
you,
behalf
ma'am.
of all the participants and Samarpan group.
Yeah.
Thank you so much, sir.
Thank you so much, ma'am, for your kind words. Yes, and I also thank Mr. Santosh, who has recommended me to you. And that is how we grow professionally. And I guess even the students who are listening to me, you can take this as an example where profession is the only thing that connects between us, even though we have n number of issues, but encouraging and motivating each other will take us far. I can see some of the students in the classroom as well. I guess the screen is projected on the classroom. And one thing I would like to appreciate, what I've seen as a new concept here is the webinar series on adult health nursing. It is a very good initiative, I felt personally. I even discussed with Jitendra sir. I think he was there a couple of days ago as a resource person. I told sir, sir, why don't we also borrow this idea from Samarpan and do this particular activity? Because adult health nursing is such a big ocean. N number of topics are there, so many disease conditions and so many things. Students usually end up being confused and all these things. And this kind of webinar series brushes up their knowledge from a different person, different taste, different way of presentation. Some things, if they retain in their minds, it will definitely help you to pass your examination, which is, I think, basically the objective of this session. Anyway, so without doing further ado, let me share my screen. I guess the slides are visible. Shashank sir, can you please confirm? Are my slides visible?
Yes, sir.
Okay, great. I'm not putting into the slideshow just to be sure that I'm on the right page.
सर स्लाइड शो
Sometimes,
को थोड़ा
due
बड़ा कर
to,
लेंगे.
yeah, I'm sure. For
Yes,
example.
sir. सर स्लाइड शो को वैसा कर दीजिए, वो हो जाएगा
Yeah.
साइड में.
नहीं मैं स्लाइड शो करना नहीं चाह रहा हूँ
ओके
दैट इज
ओके
व्हाई आई
ओके
एम जस्ट कीपिंग इट
ओके
बिकॉज कभी नेटवर्क लैग हुआ तो मुझे पता नहीं चलेगा वेयर आई एम
ओके सर
हैंगिंग
ओके ओके सर.
ओके आई होप दिस इज कंफर्टेबल एंड विजिबल
यस सर.
anyway so the topics that were given to me was basically a broad umbrella term on oncology and in that I am supposed to talk today on the basics of oncology, the tumors and malignancies and the treatment of them.
आई थिंक देयर इज ए नेटवर्क इशू. Please wait. There is a network issue. Sir, soon join.
Am I audible now?
Yes, sir.
Yeah, I'm just turning off the video to avoid network issues. Please
Yes,
bear
yes.
with me.
Okay.
Yeah, so I was saying that we'll begin with the oncology terminologies, which are basically and commonly used in cancer. We'll also talk about some hallmarks of cancer, the typical characteristics of a cancer disease, along with the pathways, like how the cancer can break through into the system, leading and affecting to different cells and tissues of the body, and the etiological factors in some cases, along with the preventive strategies, some screening methods and tests that we can come across for diagnosing cancer at early stages so that we can have better life prognosis for the patient, which also includes the diagnosis and the staging methods, the TNM classification thing. And we will also see the role of surgery in different dimensions, like how surgery is not just a part of treatment, but many other aspects related to cancer. It is an inevitable option in most of the cases, and it is really a helpful, modality, we can say. Apart from surgery, we have definitely chemotherapy as well as radiation therapy, which is associated with the nursing responsibilities, and then finally with the classification and nomenclature associated with the cancer conditions. So, as we know, cancer is definitely a global burden these days. It is a burden in terms of a non-communicable disease, which is affecting the whole globe, irrespective of the, ethnicity, the economical status of the nation, or whichever nook and corner of the globe you belong to. It is seen in every aspect of life, every walk of life, you can say, where WHO has estimated about 10 million deaths in 2020, and you can see the economic burden reaching to around $1 trillion annually, which is humongous. So, which is a huge financial burden. And I think even the International Nurses Day theme, if you see, it is associated with how the nurses can help in reducing the economic burden by investing in the nurses, by improving their knowledge, by skills, and by conducting such webinars, CNEs. These all things matter. In the long run, these things are kind of investment which are going to help you reduce the burden of the disease. And one among the disease that we're talking is about the cancer. So moving forward, let me take you through the terminologies that we are going to see. I guess the students who are listening to me are already aware about these terms, but still let me take you through very quickly. You can make a note or you can take a pic or screenshot, whichever is comfortable to you. The entire presentation I've designed in such a way that it is not very much as it is a copy paste of curriculum. No, it is completely different. But I've tried to cover everything in a concise manner so that it can help you in your examination because, kind of notes you can say when you're preparing for exam. And I'm sure oncology is one of the important units in adult health nursing. And I request the students who have as a part of curriculum to please listen attentively. Fine. The first term we have is neoplasia. So, as you know, neoplasia stands for representing a group of cells which are completely new. All of a sudden, a new kind of structure, a new kind of morphology starts to appear inside the body. Such a type of group of cells we call as neoplastic cells. And these proliferation then takes us forward, leading to a stage called as tumor or cancer. And then we have the next term as hyperplasia. So, and after that, as you can see, there is another word, hypertrophy. Many students I come across, when I go to the clinicals or in the class, when I ask what is the difference between hyperplasia and hypertrophy, many end up getting confused. So, this is one more time to have a clarification. Hyperplasia means, remember, it is a increase in the number of the cells, that is proliferation in the number of cells. And because of that, even the size also increases. The whole tissue appears big. But basically, the reason behind that is the multiplication of the cells. And there is hypertrophy, which is the cells are not multiplying basically, but each individual cell is getting swollen up. Okay, they are getting swollen, they're getting enlarged. So that is nothing but the hypertrophy. I'm sure we are clear up till here. There's the next term called as dysplasia. So dysplasia is a kind of precancerous early stage of the cells which are going to be seen in a biopsy or in a kind of pap smear, we can say, where they show some kind of distortion from the normal structure or normal anatomical morphology of a cell. That we call it as dysplasia. And then we have carcinoma in situ, which means now, now we are sure there is a cancerous kind of thing happening in the body, but thankfully it is now restricted itself to one origin point. So from whichever area, whichever part of the body, whichever organ it is associated, where you are seeing neoplastic changes, it is restricted only to that particular part of the body. So that we call it as carcinoma in situ. So next time, if you see in a patient's chart or in a cardex where they've written carcinoma in situ, gallbladder or something, it represents that the cancer is originating from the gallbladder, and so far it is identical to that particular thing, and now it has lost its identity originating from that particular tissue. Okay. And next term is the invasive carcinoma, or you can say as metastasis as well. So invasive carcinoma, as you know, or the meaning of metastasis, where the cancer cell is now ready to spread and attack to the neighboring tissues, the neighboring cells, and the even the distance as well within the body. Like say, the bladder cancer can migrate into the lungs, or even thyroid cancer can reach into the brain, and vice versa. So this is nothing but the metastasis, where the cancer kind of cells are now traveling from their origin of site to different places in the body and spreading the disease across different tissues and indirectly affecting the entire system. The next terminology we are going through is adenoma. So adenoma, as you know, is a abnormal growth, we can say, which is seen especially in the glandular kind of tissues. Okay, usually in the glands when they start swelling up abnormally, where there we see the neoplastic changes happening in these kind of structures, we call them as adenoma. Then we have sarcoma. Sarcoma is the cancer that usually affects the supporting structures, the connective tissues, the soft tissues, especially the bone cartilages, the muscles, as well as the fat tissue. Some examples you can see here are the osteosarcoma. Then we have chondrosarcoma. Then leiomyosarcoma are some of the examples. I'm sure you must have already gone through these terminologies. Now let us step into the another part. Now here I would like to request students, especially fourth sem or whoever has part of curriculum, to make a note of this. The characteristics or the typical kind of features or traits that the cancer carries with itself is called as the phenotype of that particular group of cells. So Abhiham, what we are saying is whenever we use the word cancer, तो हमें कौन से features, what are the salient characteristics of that particular cell that we are looking up to? Okay, that is the meaning of this heading. So here we see the first feature, the first characteristic a cancer tissue represents is autonomy. So what is autonomy? Can anybody quickly type the answer in the chat box? What do you mean by autonomy? Anyone? Anyway, so autonomy is nothing but freedom. Okay, they are free to function on their own, which means they don't take any kind of dictation or the rules and regulation given by the DNA, given by the nucleus, or given by the genes, you can say basically. They don't listen to any genes that you should be of this particular size, ऐसा structure होना चाहिए, इतना ही grow होना चाहिए. ये सब rules and regulation को they don't obey. Okay, they are completely autonomous. And the second feature is they are insensitive to the anti-growth signals. Okay, whatever warning the body is trying to give through different hormones, through different biomarkers, इन सब चीजों को ये ignore करते हैं. They jump all the signals, they jump all the rules, and that is a typical feature of a cancerous kind of cell. And then we have limitless replicative potential. That means it can grow to n number of cells, or it can grow to any extent in terms of the size as well. So that is the meaning of limitless replicative potential. And then the final characteristics is the tissue invasion and the metastatic property. So that we have already seen in the terminology, every cancer cell has a potential to spread from its origin site to any part, any system, starting from the closest to the distant tissue as well in the body. So these are some of the hallmark features of the cancer. That is autonomy. They are insensitive to any kind of warning given by the body itself to not to grow in a rapid manner, and resistance to any kind of apoptosis. They are reluctant to any kind of self-defense mechanism the body is trying to have, either by swallowing them, killing them. They become resistant to each and everything. And they have the immense potential to replicate at a uncontrolled speed. And they are obviously going to spread to different parts of the body. Moving forward, we will now see the different pathways to the cancer. Okay, so pathways to the cancer means how basically cancer manages to enter our system, how a normal cell all of a sudden becomes a terrorist for the body. So that is what this pathway of cancer means. So if you see the first point, it says exposure to the environmental carcinogens. So, cancer doesn't have any specific list of etiological factor. They're only risk factors, they're only aggravating factors, they're only factors which can make vulnerable to a person to get this disease condition. So one among them is exposure to the environmental carcinogen, which means even in a surrounding right now at this given point of time, the air that you breathe, the water that you're drinking, the food that you eat, everything has a potential to give a carcinogenic effect to the body. We all consume water from the plastic water bottles. We consume sometimes tea, hot tea, or hot beverages in plastic cups. So these are all some of the examples where even in the environment, there are some carcinogenic agents ready to enter our body and cause cancer. The second one is dysregulated DNA repair. Now, dysregulated DNA repair means there is no control, there is no regulation, or there is no rules and regulation for the DNA to replicate. All of a sudden, as and when it likes, it pairs with any kind of sugar bases. There is no thumb rule being followed about how to maintain the genetic structure. Everything is distorted. So that is dysregulated DNA repair. And then we have random replication errors. So here we have like replication is going smooth, but all of a sudden there is a mutation. All of a sudden there is a jump in the sugar coding. So that is the phenomenon we call it as random replication errors. And then finally we have hereditary germline mutations, which means that we carry from our ancestors, from our father, from our mother, and that is embedded already in the genes that this is bound to happen. मतलब आपको ये particular cancer होने की संभावना already हम अपने biological parents से ये लेकर आते हैं, where there is a mutation going to happen in a particular gene foci. The particular location of gene is already been told that you are hereditarily sent, my friend, and you're going to cause cancer when you reach a particular age. So this is about the pathways to the cancer. Next, we have some genes responsible for the cancer. So like I was telling you that we get all these things already pre-programmed in the genes. Mostly it is related to the errors in the DNA replication or gene multiplication. So let us see which are those genes who are, notoriously responsible for the oncotic changes in the body. The first one are the oncogenes themselves. So oncogenes are already the mutated genes which are leading to cancer. They cause the cells to multiply in an abnormal fashion, leading to neoplastic cells all around the tissue. And now they are basically the originating factor for this particular cancer. Then we have tumor suppressor genes. Usually, these are the kind of genes which try to control the neoplasia. Like I told you, the typical hallmark phenotype I told you, they try to jump every signal. So here, this gene which is responsible to control the cancer, even that is bounced. So the cells don't obey to these genes. And that is how they end up becoming uncontrolled multiplication of the cells. And then we have stability genes. So these stability genes are actually responsible to give stability while the cells are multiplying through mitotic replication and control or decide the way how the DNA should, transform from one cell to the other cell. But when these genes are mutated, when the stability genes are affected, that will again lead to the causation of the neoplastic changes. And all these genes are somewhere directly or indirectly involved in the oncotic changes which are going to happen as a part of the cancer. I hope I'm clear until now. Let me know if I'm too fast or you want me to use a bit of Hindi as well in between. Fine. So moving forward, we have the next topic to cover, that is the etiological factors. Like I told you, there is no one particular pinpoint etiological factor in case of cancer, but many research studies have put forward, uh, a strong association between some factors which are directly connected to a particular system's oncotic changes. Okay, for example, if you see tobacco, when you say tobacco, which is consumed in the form of smoke or in chewable form, in either of the cases, it is obvious that the tobacco consumption has more closer association in the causation of cancer associated with lungs, with esophagus, the head and neck area, the stomach, the pancreas, the kidneys, the bladder, and even the cervix. Then we have alcohol. So alcohol also has a potentiality to cause the cancer, where it is directly linked with the possibility of causing oncotic changes in the oral cavity, especially of the squamous cell tissue, the pharynx, the esophagus, liver, obviously, then rectal, as well as in some cases the breast cancer. And then we have asbestos. So asbestos usually, it is kind of lung disease caused by inhalation of this particular chemical. So usually it is associated with the respiratory area where oncotic changes can be seen in the lung, or especially the mesothelioma of the lung tissues. Then we have the infectious agents, especially hepatitis B and C virus, or even the HPV virus. These are all the viruses which are known to cause cancer. Even though it is a virus, it still can cause a cancer, especially of the liver and of the cervical cancer, anal cancer. And somewhere it is also found that even the HIV virus can also make a person at risk to develop oncotic changes by smashing the immune system of the person. So these are some of the examples where even the infections can lead to cancer. Then the pharmacological agents. So consumption of certain pharmaceutical products or the combinations, especially when we consume hormones as a replacement therapy, which is associated with the uterine as well as the breast cancer affecting the female population mostly. And then we have the diet. So obviously coming to the lifestyle, which is a these days a very common cause for every disease condition, we can say. Lifestyle, so हर किसी disease condition में it is associated nowadays. So obviously having a wrong diet or incorrect consumption of food style can lead to the cancer of the colon, the stomach, even the breast, as per the research studies. Then quickly talking about the cancer prevention. So as you know, we have been studying about the three levels of prevention: the primary prevention, the secondary prevention, as well as the tertiary prevention. So the main objective in the primary prevention is to see that, and in the first place, there is no contact between the etiological factor and the body itself. So you break the chain. You don't allow the person to expose himself to the positive, the possible risk factor, so that there is no question of the cancer arising in the body. Now, let's say that is not possible. Somehow you got exposed, somehow the etiology entered into the body. Then comes the secondary prevention, where you have detected with the disease has already originated within you. Then obviously the challenge that stays with us is to prevent the symptoms from getting more aggravated, to prevent the spread of the illness within the body. We are in the secondary prevention. Our main objective is to control the symptoms as well as to control the metastatic activity of the cancer inside the body. Okay, that is the main objective in the secondary prevention. And in tertiary prevention, now that there is metastasis and everything is gone beyond control and there is very less left to do, in those cases, we are going to focus on the palliation, the palliative care aspect of the cancer patients, and reduce any kind of complications if there is any successful treatment or surgery being done. Make sure that there is no, rebounding effect or boomerang effect of any kind of treatment or the therapy or any last stages of cancer which is affecting the patient. Okay, so this is about the cancer prevention. Then let us quickly go through the screening tests. So screening tests, again, this is a very important, even from the exam point of view, you may get short notes or even short answers about list any two kind of screening test in cancer, something like that. So usually mammogram is advisable for women above the age of 50 annually, and so is the clinical breast examination. We are not talking about the self-breast examination here. We're talking about the clinical examination of the breast. See, many times, no matter how many times we nurses give health education, we give counseling, we do role plays and so on or whatnot to create awareness about the self-breast examination. Still, when a woman detects something lumpy when the examination is being done, the next thing they should do is to visit the clinic or the hospital and get themselves examined thoroughly for clinical confirmation of uh, the tumor or the growth which is being seen. Then annual pap smear kind of test is advisable for reproductive age women who are sexually active. And then the other tests in the screening process include the fecal-occult blood tests, sigmoidoscopies, or barium enema. See, all these things are sounding theoretical though, but it is sometimes highly important that we take care of these things, at least in people who are at risk. If you know that in your family there is already a case of cancer, somebody has lost his life because of cancer, then you automatically become a high risk group. So it is advisable. See, सब लोग तो जाके ये नहीं करवाएंगे, हम चाहे जितना भी बोले, लेकिन कम से कम उन लोगों को हमें फोकस करना चाहिए, उन लोगों में हमें ज्यादा फोकस देना चाहिए जिनमें ऑलरेडी स्ट्रॉन्ग हिस्ट्री है फैमिली में, जहाँ जेनेटिक प्रीडिस्पोजिशन बहुत स्ट्रांग है, या कोई ऐसे ऑक्यूपेशन में है वेयर दे आर वेरी वल्नरेबल टू गेट दिस पर्टिकुलर ऑन्कोटिक चेंजेस, एटलीस्ट उनमें तो annually they have to get examined themselves or whenever possible just to be sure कि कहीं बहुत देर ना हो जाए to diagnose the condition. Okay, fine. So moving forward, then we have the genetic screening. So again, like I told you, the genes play a notorious role in causing this oncotic changes, especially by toppling, completely distorting the gene multiplication at the DNA level, causing all the disturbances in the oncotic changes that are going to take place in the body. So genetic screening is also one of the important dimensions. Then let us look at the diagnosis and the staging part. So in the diagnosis and staging part, we are going to talk about how to diagnose and also how to stage. So diagnosis, as you know, there are different approaches. There are radiological approaches, invasive approaches. There are different kind of blood investigations that we can do. Apart from that, what goes hand in hand along with the diagnosis is the staging. सी डायग्नोज तभी हो पाएगा जब हम एक्यूरेटली कैंसर को हम अप्रोप्रिएटली स्टेज कर सकते हैं कि व्हेन यू लेट्स से यू टेक अ बायोप्सी ऑफ अ पर्टिकुलर टिश्यू एंड सेंड इट फॉर इन्वेस्टिगेशन, आपको पता चला कि हाँ इसमें ऑन्कोटिक चेंजेस है, नियोप्लास्टिक सेल आपको दिख गए, सो दैट इज नॉट द एंड ऑफ द स्टोरी, दैट इज नॉट ओनली द डायग्नोसिस. उसके साथ साथ वी ऑल्सो नीड टू स्टेज कि ये कौन से हद तक हैं, इन विच कैटेगरी दे बिलोंग टू. So that is when something called as the TNM classification comes into play. So TNM classification, I guess you already must be aware about this. That is, the T stands for what? Anybody? T stands for tumor. N stands for, yes, node, involvement of the nodes, and M stands for the metastasis. So TNM stands for tumor, involvement of the lymph nodes, as well as the metastasis. So usually when we talk about TNM classification, it is graded across the stages of 1 to 4. Okay. So 1 is a less risk or no risk, you can say, and 4 represents more advanced stage or very late stage, we can say. So in the staging, when you see, we have the representation of that I've brought here. You can see here. Stage 0 means there is no cancer. Stage 1 means the cancer is small and it is restricted to only one area. Stage 2 and 3, they mean that the cancer is large enough and is and has grown into the nearby tissues. It has metastasized, but it is limited to around only to the surrounding structures. And in stage 4, you can see that this cancer has now spread to almost every other part of the body and becoming more uncontrollable situation. So these are the staging of the tumor classification, we can say. Okay. There is an example you can see here, T2 N1 M0, which means T2 stands for the size of the tumor which has been growing, and N stands for the number of lymph nodes involved in that particular anatomical structure of the body. Let's say in colon, there are 16 lymph nodes in the colon area. Out of those 16 lymph nodes, only one lymph node is being involved. And metastasis is at 0 stage or, kind of spreading to the nearest structure. And the staging can be given respectively in the brackets. Then next, let us look at the role of surgery in cancer. Like as I told you, surgery is not just a part of treatment, it is also helping in different dimensions of the management of a cancer patient. The first one is prevention. Surgery helps in prevention. Prevention of what? Prevention of further spread of the cancer to different parts of the body. When there is a surgical excision or removal of a particular part of the body which is undergoing an oncotic change, then that helps in removing of that lesion, causing risk to the spread in the surrounding structure. Is it not? And also, wherever the in situ was originating, that also has been chopped off. So that also further reduces the possibility that it can further regrow or convert back itself into a neoplastic cell. Then the second role of surgery in cancer is in diagnosis. Okay, whenever we do surgeries, we take biopsies, we send samples of the body tissues for further investigations to the pathology lab, and we get to see exactly where do we stand in terms of the tissue damage or how much of the tissue is involved in terms of the replication of the neoplastic cells. Then finally, of course, it is involved in the treatment. Surgery definitely helps in treating the cancer, especially by removing the primary tumor where the origin of cancer is being spread. अब जब मेटास्टेसाइज हो जाएगा, अलग टिश्यूज अलग पार्ट ऑफ बॉडी को स्प्रेड हो जाएंगे, तो एवरीवेयर सर्जरी मे नॉट बी पॉसिबल, but at least wherever the cancer is originating, at least in that particular part, if you can remove it from the roots, it is going to give a big relief to the patient in terms of the outcomes. Okay. And also further, if you see, because of the surgical interventions, we get to see the involvement of the staging. We get different samples of lymph nodes and identify how much of the lymph nodes are damaged, how much of the lymph nodes are involved in this particular thing. And in reconstruction as well. Okay. After the surgery is being done, the cosmetic changes that we can do in the patient to, appear aesthetically not so vulnerable in the society. Okay, like for example, if somebody has undergone mastectomy because of breast cancer, then there are reconstructive surgeries of the breast so that the woman does not have to feel awkward, in terms of the body image disturbances. So many things are associated with the surgical corrections. And finally, with the palliative aspect. So through surgery or using surgical approach, we can also create palliation. That means when you know that the patient is going to end his life anyway because of the late development of the cancer, but still we can create a hope or we can extend the lifespan to by months or by few years or maybe by few days as well by creating any kind of ostomies for feeding or for expulsion of the waste materials So even in palliation, surgery plays a very important role. Then let us talk about the radiation therapy. So in radiation, as you know, we use the radioactive materials and we use them to bombard against the tissues or the cells which are basically affecting the particular oncotic changes here. And these things, yeah, myomectomy. Yes, myomectomy. Yes, somebody has commented myomectomy as carcinoma management. Yeah. So in radiation therapy, as I was saying you that we use radioactive materials where the radiation is bombarded against a tissue or a cell where there is oncotic change being seen. And with the help of this, we try to limit in a precise way. Radiation can be very precise, very to a particular area, we can give a therapy instead of affecting the entire body. Wherever we can see this is being seen, we can target that particular zone or tissue of the body and have a desired effect. Obviously, it comes with a set of side effects. Every therapy has its own side effects. And in radiation, the side effect is usually associated with the skin because definitely the rays are going to bombard with the skin. They are going to fall on the skin. So skin is the primary organ which is going to come in contact between the radiation. So we'll see about the skin involvement of skin, what precautions to be taken in the upcoming slides. But before that, well, let us see the chemotherapeutic agents which are commonly used. The categories you can see here are the cell cycle specific, and there is non-specific to the cell cycle agents. Then we have alkylating agents, we have antimetabolites, we have anti-tumor antibiotics, and we have mitotic spindle inhibitors. So basically, if you understand the names of these chemotherapeutic agents, they are all hitting different parts of the cell multiplication. So I request all the students who are listening to me to please go through and refresh your knowledge about the mitosis and meiosis here. Okay, I think you must have studied it way back in your first semester in anatomy or physiology. So it is good that you can, just review your knowledge about this cell multiplication to understand these terminologies better. Fine. So these are some of the examples, the table, the screenshot of the chemotherapeutic drugs which you commonly use I have brought here for your reference. Okay. So in cell cycle specific, you can see there is 5-fluorouracil, then there is methotrexate, dextromethorphan, then paclitaxel, then there is vincristine. In the non-specific of the cell cycle, we see there is cisplatin, very commonly used, then cyclophosphamide, which is again a commonly used chemotherapeutic agent. The next aspect, I think, in our textbooks of medical surgical, usually we don't cover this part, is the evaluation of the response. ठीक है, अभी हमने सर्जरी कर दी, रेडिएशन दे दिया, कीमोथेरेपी दिया, सब किया, बट इसका प्रोग्रेस कैसे असेस करें? How to know whether the treatment that you're giving is effective or to what extent it is effective if it is not completely curing. Okay, तो इसको हम कहते हैं evaluation of response. मतलब patient कैसे respond कर रहा है to the treatment that we are giving. So in this, the response rate is usually defined as the percentage of the patients who experience a response while being treated. ठीक है, जब भी हम दवाई देते हैं तो पेशेंट का एक्सपीरियंस क्या है? इज ही फीलिंग रिलीव फ्रॉम द सिम्टम्स? इज ही फीलिंग बेटर? उसके बेसिस पे दिस पर्टिकुलर रेस्पॉन्स इज बीइंग जनरेटेड. The first one is complete response. Okay, when the patient is seeing visibly that there are no lesions, or clinically you are able to establish that the complete lesion has completely abolished, there is literally no cancer left in the body, that is called as a complete response. By chance, if it is not complete, then we categorize that into partial response, where maybe 30% or more reduction in the size of the tumor cells we can see. Then in that case, we call them as partial response. Then we have something related to the progression. That means response in a negative way. मतलब कम नहीं हो रहा है और ज्यादा हो रहा है. So there are new lesions seen in the body, new tissues, it is getting metastasized to different parts of the body. या फिर जहां था वहीं पे proliferation ज्यादा हो रहा है. या hypertrophy ज़्यादा हो रहा है of that particular part. So this is all in the progression. And there is another stage where we call it as stable disease. That means na response है, na progress हो रहा है. Nothing is happening. It is just standstill. ठीक है, neutral effect you can say. जिससे डिसीज ना आगे रिकवर हो रहा है ना और ज्यादा डिटोरिएट हो रहा है. सो दिस इज स्टेबल डिसीज. तो इन सब कैटेगरीज में वी कैन रेस्पॉन्ड द वे द पेशेंट इज रिएक्टिंग टू द ट्रीटमेंट. ओके, fine. Now that brings us to the second section of the topic that was given to me, which is the tumors and malignancies affecting the different body systems. Okay, so we have completed with the basics of oncology so far. So इससे पहले कि हम आगे वाला हिस्सा डिस्कस करें, let me just recapitalize what we have discussed so far. अभी तक हमने सिर्फ बेसिक ऑफ ऑन्कोलॉजी देखा है, मतलब एक ओवरव्यू एक किस्म से. So we have seen terminology, we have seen the characteristics, we have seen the pathways, we have seen different modalities, what are they, उसके outcomes क्या हो सकते हैं, okay, all these stuffs. So अभी हम क्या करेंगे, we are going into each system, ठीक है, like each and every part of the body, हर एक organ में, हर एक system में कैसे कैसे type of cancer हो सकते हैं. मैं बस नाम list out करके लेके आऊँ so that I'm not eating much of your time, और ये आपको एक refreshing की तरह काम करे, not to bore you with a detailed lecture जो आपको ऑलरेडी आपके टीचर्स ने क्लासेस में ले लिए होंगे. Okay, fine. So let me give an overview like how exactly the different types of cancer are there. You know, literature say that there are over 100 different types of cancer. अगर आप एक एक का नाम लिखते बैठोगे तो ये more than 100 हो सकते हैं. So but इसका यूनिकनेस क्या है कि every type of cancer is unique in its own way. उसका अपना इटियोलॉजी है, अपना ही सिम्टम है, अपना ही ट्रीटमेंट अप्रोच है, अपना ही एक आउटकम है. सो एवरी कैंसर इज यूनिक इन इट्स एग्जिस्टेंस, बट द टाइप्स कैन बी ऑफ n नंबर ऑफ टाइप्स. ओके, सो लेट्स सी हाउ टू ब्रॉडली क्लासिफाई. अगर आपको ये पता नहीं है तो आप ये नोट कर सकते हैं. द टाइप्स ऑफ कैंसर विच इज क्लासिफाइड बेस्ड ऑन द बॉडी सिस्टम्स. ओके, सो हियर सी कैंसर एक ऐसा कंडीशन है जिससे हमारे बॉडी का कोई भी टिश्यू, कोई भी ऑर्गन बच नहीं सकता. ओके, एक्सेप्ट नेल्स, एक्सेप्ट योर हेयर एंड एक्सेप्ट योर टीथ. ये तीन चीजें ऐसे हैं जहां पे कैंसर हमें यूजुअली देखने को नहीं मिलता, या रेयरली, बहुत रेयरली देखने मिलता है. अदरवाइज देयर इज नो सच पार्ट ऑफ द बॉडी वेयर कैंसर इज नॉट सीन. एंड यूजुअली जब हम कैंसर के नाम रखते हैं जहाँ पे जिस बॉडी पे वो जा रहा है, जिस हिस्से में वो मेटास्टेसाइज हो रहा है, दैट ऑल्सो हैज अ नॉमेनक्लेचर, स्टाइल है एक नाम रखने का कैंसर को. सो यूजुअली जब एक कैंसर लेट्स से इज ओरिजिनेटिंग फ्रॉम लंग्स, ठीक है, लंग्स में ओरिजिन हुआ और वो स्प्रेड होके पहुंचा लीवर को. तो जब लीवर को कैंसर हो गया जहां लंग से ओरिजिन हुई थी, तब भी हम पेशेंट को लंग कैंसर का ही डायग्नोसिस का नाम देंगे. वी विल नॉट से द पेशेंट हैज लिवर कैंसर और लंग कैंसर, लंग एंड लिवर कैंसर, ऐसा नहीं. जहां से ओरिजिन होता है वही नाम होता है डायग्नोसिस का. इज दैट क्लियर? सो फ्रॉम द ओरिजिन irrespective of whichever part of the body it is going to metastasize. Is that clear? Okay. So I told you already about the nomenclature, how it is given. So now talking about the different blood systems. So पहला system है blood. So blood cancer, we know blood cancer is clinically one of the very common and more frequently seen kind of cancer. So you can see here blood cancer we categorize into different sections. We say acute lymphocytic leukemia, ALL. Then we have myeloid leukemia. Then we have lymphocytic leukemia. Okay, then we have Hodgkin's lymphoma, non-Hodgkin's lymphoma. So these are all the things which are associated with the blood and the lymph inside the body. Okay. Similarly, we have, the next one, which is the bone cancer. Okay, which is affecting your musculoskeletal system. So usually bone cancer as such is very rarely seen, but when it is seen, it is mostly seen in the form of sarcoma. Okay, so you can see here there is Ewing sarcoma, there is osteosarcoma. In the beginning slide also I've given you these examples. which are mostly seen affecting in children or in teenagers. Okay, they are more prevalent in this age group, although they are seen in adults, but more common in children, we can say. Then the next body system we can talk about is the brain. So brain is a very interesting part of cancer because whenever there is a brain cancer, the usually brain originating cells have less tendency to metastasize outside the cranial cavity. Usually होता नहीं है, but vice versa जरूर होता है. मतलब क्रेनियल कैविटी के बाहर के जो टिश्यूज हैं वहां के कैंसर स्प्रेड हो सकते हैं ब्रेन तक, लेकिन ब्रेन का कैंसर क्रेनियल कैविटी से निकल के बाहर दूसरे ऑर्गन को स्प्रेड होना इज वेरी रेयर. ओके, बहुत कम रिसर्च स्टडीज ये सजेस्ट करते हैं. So when you talk about the different types of brain cancer, you can see here there are gliomas of the brainstem, there is cerebellar astrocytoma and glioma of the cerebrum. Then there is ependydoma, and the even the ocular pathways of your hypothalamic and the visual pathways, even they can get affected with the glioma, and it can eventually end up with a space occupying lesion in the brain called we abbreviate as SOL. Okay. Now these SOL can be again benign, mostly benign, and very rarely it can be metastatic. The next one is about the breast cancer. So breast cancer, as you know, it is very common in women than compared to men. सनी की men में नहीं होता, but it is very less in terms of the the mortality rates and the morbidity rates. So usually we see ductal carcinoma, we see lobal carcinoma, and we have patches disease of the nipple, and sometimes invasive types of breast cancer which are metastasizing to the different parts of the body as well. Okay. And talking about the digestive system, which is a house or home for many organs and many systems in the abdominal cavity. So here we can range from anal cancer to liver cancer or the bile duct cancer, pancreatic head, body and tail, different sections of that can be seen with oncotic change. Esophagus can be involved, buccal cavity, mouth, okay, the squamous epithelium inside that, salivary glands, I've told about adenocarcinoma, the glands can be affected. So all these things are affected in the GI system. Then talking about the endocrine glands. So the endocrine glands are the ones, which produce the hormones. And when we talk about hormone, the obvious name that comes to our mind is the thyroid gland. Yes, thyroid gland is definitely one of the very commonest type of cancer, but it is also less lethal. No, the mortality rate associated with the thyroid cancer is also significantly less. Apart from that, we get to see adrenocorticoid carcinoma. Then we have, islet cell carcinoma in the pancreas. Then we have pituitary tumor. Okay, so all wherever there is endocrine kind of glands, every gland has a possibility of getting oncotic change in them. Then even the eyes, see, even the eyes are not spared. Okay, so even the intraocular area of the eyes can be seen with a melanoma. Then there can be retinoblastoma, where the oncotic changes in the eyes also can be seen. Then in line with this, we have the genitourinary cancers. So where usually the excretory system as well as the reproductive system both are represented here. So we can see very commonly the bladder cancer, prostate cancer, again very common in men after the age of 60. Then penile cancer, renal cancer, urethral cancer, testicular cancer. All these things can be very commonly seen in the genitourinary system. Okay. Again, अभी जितने भी हम सिस्टम पढ़ रहे हैं इन सब सिस्टम के स्क्रीनिंग, डायग्नोसिस, स्टेजिंग सब सेम रहेगा. Okay. And then in the gynecology, we have the gynecological set, the female pelvic organs which are there, originating to that, you can say endometrial cancer, ovarian cancer, cervical cancer, vulvar cancer. Okay, so that is where the pap smear analysis comes into a key role in diagnosing and staging the particular cancer in these areas. The next comes the head and neck cancer. So head and neck cancer usually has a typical feature. Okay, it usually affects the tissues which are moist. Okay, That means the buccal areas, the mucosal glands, you can say, in this area are very commonly affected. And smoking is one of the very notorious cause for the head and neck kind of cancer. Many times we have seen in the wards that patients suddenly get surprised. You know, how come, kind of salivary gland cancer ho gaya? Even though I'm smoking se to patient feel that lung cancer hona chahiye. ऐसे कैसे salivary gland ho gaya? No, it is not like that. Whenever the smoke is inhaled, it is coming into all the cavities, all the tissues are exposed, and anywhere, whichever cell, whichever gene is giving up on the replication, that particular area can get affected with the neoplastic changes. Okay. And then obviously the respiratory system we have where we can see the lung cancer. And usually now again, lung cancer has the main notorious cause of the smoking. Apart from that, we have asbestos inhalation, pollution these days, okay, industrialization, occupational hazards place men vulnerable to get respiratory cancers. Okay. Then skin cancer. So skin cancer is also one of the common conditions we can see, especially with respect to the skin organ, where there is non-melanoma kind of skin cancer. That means the cells which are responsible to produce melanin, these cells are not involved. Okay. Apart from that, the normal cell like squamous epithelium, cuboidal epithelium, these all the kind of tissues which are involved in the skin cancer. Okay, not the melanocytes. Okay. Fine. And then coming to the last part, which is the cancer modalities, we can say. So cancer modalities, we are talking about the treatment approaches that we can have as a part of cancer treatment. So in cancer treatment, like I told you, it is mainly associated with the surgery, the radiation therapy, the chemotherapy, and the immunotherapies. But the decision of which therapy to choose depends upon the histological type of the cell, the kind of cell, the cell structure, the cell morphology, the stage of cancer, the presence of metastasis, whether it is metastatic or benign. ये सब चीजें भी matter करते हैं for all these things. And also the condition of the patient, the kind of response the patient is giving to the other treatment methodology. Based on that, we make a choice of that. Okay, this is the same thing we have. So when we talk about the chemotherapy, as you know, we use chemotherapeutic agents, the pharmaceutical agents, which are a combination of different chemical products, usually targeted to kill the tumor cells. Okay, these are designed to kill the cells which are neoplastic. They are not listening to any other kind of genetic control. We target such group of cells. So here, when you see the primary objective of using chemotherapy is to control or kill the cells which are multiplying in an uncontrolled, rapid fashion. Okay, this will indirectly also prevent the possibility of metastasis into different tissues. अभी जो हमने देखा different systems of different types of cancer. इन सबको होने के रोकने के लिए भी we need to use chemotherapy. Okay, so chemotherapy is one of the baseline approach to treat a cancer. But along with that, we also have a combination of radiation therapy, and also along with that, we can also use medical therapies associated with that. Okay, so let's see how these things are going to work. So the primary goal of chemotherapy is to cure, to control, and for palliation. Okay, so to cure, we are going to use the cure to completely treat the cancerous cell, to control in order to limit the possibility of metastasis of the cancer to different parts of the body. And palliation, if at all the patient has advanced to the last stages of the cancer, in those cases, our objective will be to make it as less painful as possible, make it as comfortable as possible for the patient to exit this particular life with the help of the chemotherapeutic agents. Then we see the classification of the chemotherapeutic agents. हम कैसे classify करते हैं इनको? So the first classification is as the alkylating agents. The second one is the anti-metabolite agents. So alkylating agents means these are the chemotherapeutic drugs which basically target, or they try to disturb the DNA replication process. They try to alter the sugar base which is going to happen in the DNA replication. And in anti-metabolite agents, these are the kind of therapeutic agents which are going to completely blast the metabolism of the cancer cell. They don't allow them to have a normal metabolism. They completely take them on a roller coaster ride and confuse that cell and try to force it to kill itself. Okay. And then we have anti-tumor antibiotics. So these are the kind of cells, again, trying to restrict the cells from metastasizing from one place to the other. And there are some plant extracts of the alkaloids, which are also acting as a cytotoxic effect on the oncotic cell. Then let us talk about the planning of how to give this particular medications. Usually, the dosage and the schedule, which are usually called as cycles, first cycle of chemotherapy or 2 cycles of chemotherapy. The dosage usually defined in milligrams. So this is how we try to usually plan the chemotherapeutic agents. And it comes with the nursing responsibilities associated with that. Okay. So whenever a patient is receiving chemotherapy for cancer, then as a nurse, we have certain responsibilities to take care. So what are they? It could be to prevent the patient from any cross infection. So always try to wear a mask or PPE. Even advise the patient to use the same. Okay. Then advise the patient to wash the hands regularly with proper antimicrobial agents. Then advise the patient not to go into the crowdy places, so that because his immune system is already compromised, he's not going to act as an opportunistic host for any other diseases. So it is advisable not to send them to any crowded places. Then good nutrition is one of the important aspects. So provide nutritious diet. Make sure the patient is having sufficient amount of calorie intake or protein intake so that the healing is taking place appropriately. And it is advisable to give antiemetics before we start the chemotherapy, usually 1 hour before, so that the patient doesn't have too much of discomfort associated with the nausea and other complications which may come out of chemotherapy. Okay. Then measuring the body weight twice a week is also advisable. Okay, just to make the patient doesn't go step into cachexia effect due to the cancer. And observe the patient for any visible manifestations of the side effects or any noted adverse effect so that we can timely intervene, prevent any complications associated with the chemotherapy. Then also we have bone marrow transplantation. I think you must have heard about this term. So bone marrow transplantation, we usually transplant the bones marrow from a patient who is healthy into a patient who is vulnerable to get oncotic disease, so that he can bounce back with the production of good amount, good number of cells, good quality cells inside the body. So that is called as a bone marrow transplantation. The simplest way of understanding. Okay, and then even when we give bone marrow transplantation, that also comes with certain nursing responsibilities. Very commonly, we get to see dyspnea or chest discomfort in the patient as a part of complication of bone marrow transplant. So please observe for that, monitor the vital signs regularly, monitor any signs of infection because the bone marrow is getting manipulated. The immune system may go at a toss. So we should be very careful about the immune status of the patient. Watch for any signs of bleeding because the platelets and other stuffs may be disturbed because of the bone marrow transplantation. Okay, and along with that, make sure you maintain proper fluid intake and also the electrolyte balance in the patient so that there is a complete homeostasis maintained within the patient's body. Is that clear? Okay. The next talking about the radiation therapy. So when we talk about the radiation therapy, as I told you earlier also, we typically try to use the radioactive materials here so that the rays are sent to the particular group of cells or targeted area in the body so that they can kill the cancer cells. So this can be given in two approaches, that is external radiation or internal radiation. So when we talk about external radiation therapy, we use, we administer by a machine or at a certain distance from the body, and the rays are then projected targeting the specific part of the body. Usually, it is done in case of bladder or breast cancer, cervix cancer. Kind of from a distance we bombard the rays to that give targeted part of the body. In internal radiation, what happens? We use brachytherapy. I think you must have heard about these names. Where different kind of radioisotopes are placed in a small holder, or sometimes in a capsule, sometimes in a beads, or sometimes in a catheter form through plastic wires. It is inserted to the closest part of the body, and then it is allowed to stay there for some time, maybe sometimes for a few days. And these radioactive isotopes then release their rays into the surrounding cell, which act as a cytotoxic agent to the neoplastic cell, and hence they produce an effect of killing the cells and by controlling the spread of the cancer. This is usually accompanied along with the surgery. After the primary removal of the tumor, it is complemented with radiation therapy along with the augmentation of the chemotherapy, which collectively bring a synergistic effect in the patient. Okay. And then talking about the common side effects, remember I told you earlier that we'll talk about the skin reaction later. So skin reaction is one of the commonest side effect of the radiation therapy. So how to prevent that? So the preventive measures include to keep the area always dry. Okay, and we should advise the patient to wash the skin with a very mild soap and use a mild shampoo in case if it is being done for the head, and wear loose and comfortable clothing so that it allows for proper ventilation, and doesn't cause any skin irritation by friction of the cloth on the area of the skin which is getting radiated. Okay. I'm a bit fast so that I have a crunch of time because I need to leave. So I'm a bit fast. So please bear with me for that. And the second side effect that we can expect is the fatigue. Okay, usually the patients get enormously tired. Okay, fatigue and malaise are very, very commonly seen in cancer patients. So for that, or we should advise the patient again to limit their activities, to maintain the physical strength, advise them to do proper daily exercises, hydrate themselves, keep them hydrated, maintain the electrolyte levels. Hydration also improves, helps in eliminating the body waste as a part of the chemotherapy or the things which are going on. So hydration is a very important aspect. Okay. And then rest is one of the key things for the cancer patient. So thorough rest, proper rest, good sound sleep is a very important thing for a patient to recover or recoup from the particular fatigue which is caused by the treatment. You know, and then so we are now approaching the end, you can say almost. So when we talk about the nursing management here of the patients who are receiving radiation therapy, we must make sure that the procedure is properly explained to the patient, and you take appropriate precaution for yourself also, not just for the patient. Even the nurses or the patients or the healthcare professionals who are giving the radiation therapy also need to take care of their own precautions. And whenever the implant is being used, make sure it is being informed to the patient to not to make aggressive physical movements so that it is not dislocated or it is not going to harm the surrounding structures. And also, hydration again is one of the important thing, because when the patient is well hydrated, the skin has a better chance to recover itself from the irritation or the kind of reaction it is going to face through the radiation. So these are some of the things that we need to take care of the things to take care of the precautions. Okay. So these are some of the things associated with the modalities of the cancer, where we have seen about the chemotherapy, radiation therapy, and also the other parts of the treatment. So sure the things are quite clear. I've been able to justify the things in a very short panel time. I think I have not bored your students, Shashank sir.
Yes, sir. Thank you, sir.
Thank
Any
you, sir.
questions, students? Chat box is yours.
Let me open the chat box as well.
Yes, sir.
Let me end the slide share. Yeah.
Participants can ask any questions.
Yes, you're free to ask any questions.
I think, sir, there is no question.
Sure.
Thank you very much, sir, for
Thank
your
you.
heartfelt contribution today.
Okay. Thank you so
Now, for
much.
participants, Ms. Nalini.
Okay.
Good afternoon, everyone.
I think she needs to unmute herself.
Good afternoon, everyone. It is my great honor and privilege to deliver a vote of thanks on behalf of SNPs at the conclusion of today's session of our national webinar series. First and foremost, I extend our deepest gratitude to our esteemed speaker, Mr. Siddeshwar sir, for delivering an insightful and knowledgeable session on oncological disorders. Thank you, sir. Thank you once again for being a part of this initiative. We look forward to continued learning and future collaborations. We extend our sincere thanks to all the participants who joined us from across the country for today's session. We hope the session added value to your knowledge and professional growth. Thank you once again for being with us today.
Thank you. Thank you, Nalini, for your nice word of thanks. And once again, I thank the Samarpan group for having me with you today. I'm sure the students have benefited something. So I request Shashank to share the slides which are sent you in the WhatsApp. I've slightly refined them along with the students. Okay.
Ji, sir. Bill, sir.
Yeah. Thank you.
Thank you, sir. Thank you, participants.